I think it's a difficult time for all of us, and I think all of us feel like we have so much stimuli, so much information, so much change, so much pain and suffering. I was sharing that you aren't the only ones with pain and suffering. The acting commissioner, executive deputy commissioner of OMH has pain and suffering too. And I was actually thinking as I was driving down here today, because I drive around a lot, I try to listen to books on tape. And so I won't get the title right, but I'm listening to this, something like, the mastermind of Sherlock Holmes. And so, of course, I'm listening to this and, talking about how brilliant Sherlock Holmes is and frankly, how, sort of a dunderhead Watson was in terms of being able to see things. And they were saying, what you have to do is you just have to attend to the right things. There's so much noise, and that's what Sherlock Holmes was brilliant at. And so they give you some examples, and I'm trying to listen along, and of course you do that. And then I realized, and Donna, this is something I think you'll appreciate, that as a type A personality who's trying to introduce myself to the concept of yoga, I understand that as they get into the warm-up phase, and I'm like, when are we going to get into the cardio part of this? That it does take some patience, and I do think that is a bit of where we all feel like we're at right now. That there's so much coming at us, and we're trying to sift through what are those particular key kernels that are relevant to me in what I do, whether I'm an overnight residential counselor, whether I'm the acting commissioner, whether I'm running an agency, and trying to sort that out is you're sort of in the right place and where you need to be if you're struggling with that right now. What we are trying to do, and what hopefully I'm about to do, what Sherlock Holmes had to deal with, I'm about to throw a lot at you. But what we're trying to do is set that vision and hopefully be able to set that target so that as you're encountering a lot of things, hopefully you're able to focus or filter or titrate some of that based on where is it that I'm trying to go. So again, this is your first opportunity to practice in filtering, so I'm going to throw some stuff at you. So sort of starting with the big picture and starting with mental health, the majority of people with a mental illness receive their care in primary care. I think most of you probably know that, but I think it's good for all of us who have worked in the mental health system for a long period of time to remember that as we look at these changes. And with the prevalence numbers that we're all pretty comfortable with, 1 in 4 has some sort of mental health issue within any particular point in time in a year. 1 in 17 would have a serious mental illness. When you think about the population of New York State, nearly 20 million, that's a lot of people. In the public mental health system, which, by the way, I'm also a proponent of one public mental health system, not a state system, not a local system, and we're going to get into that in a minute. But in that public mental health system, we serve 700,000 individuals each year. The other question, and I'm sure all of you were tuning in to watch me give my budget testimony this year. It's great. It's on YouTube, I think. I don't know, none of my kids have said they've looked at it. I can't figure out why. But one of the questions that I very frequently get is, well, how are your services different from OPWDD? How are you different? What's the difference? And I think one of the most significant things to think about the behavioral health system, Arlene, I'm intentionally including us together, united in this, is that people recover from behavioral health issues. And it's really about episodic care. It's not about long-term care. And again, I realize I run the second largest hospital system in the state of New York. I care for individuals who have had a lot of contact with institutions over a long period of their life, and yet it is critical that we understand that from a vision standpoint, that people recover from behavioral health issues, and we need to structure our system to make sure that we're supportive of that. So really key focus for us. So I think the other challenge for us in behavioral health care, and I think Jason is probably sick of hearing this at this point, but part of our sort of bob and weave and dodge of managed care in the past, was always we're so complicated. We have not everybody we serve has just straight Medicaid. Some have Medicaid and Medicare. Some have commercial insurance. About 40% of the kids that we serve in the public mental health system do not have Medicaid, and that does not mean that they have any less of a struggle that they're working on. So We have that complexity in terms of payer. We focus on the full continuum. We focus from, my responsibilities looking at vision and planning and funding for, prevention, early access across the lifespan, and again, those individuals who have the most complex forms of mental illness and sort of everybody in between. So that makes it pretty complicated. This is a housing conference, so we have housing, we have employment, we have a variety of sort of fill-in-the-gap supportive services at the Office of Mental Health Funds. Those are kind of messy and complicated too. And so in the past, it was sufficient when we rattled off that list that, people like Jason in the past would have gone, ooh, yeah, too complicated, all right, yeah, just keep going. But now we're really at a place where we need to have the benefit of the triple aim, which Jason talked about. We really need to focus on improving the health of our population. Our population really does very poorly in terms of health outcomes. We need to improve individual outcomes, and we do need to look at cost. So we're going to have to find a way to deal with some of those complexities. I think another key vision point for us, and I'll continue to use this, and that's going to be on YouTube too, but that I think is important for us to think as we restructure is that I do see particularly the mental health system being sort of like the Statue of Liberty system within healthcare. So, we've long said, and I think a lot of this is the big hearts that we have, the commitment to trying to help people in difficult places in their life, have sort of said, oh, come on into our system and we'll be able to serve you. Even if that isn't particularly the best, the most needed aspect for somebody. So somebody may have a bunch of challenges, they go into an emergency room and they may end up in an inpatient psychiatric unit or may end up in the behavioral health system. So I think the challenge for us is how do we maintain our vision? I'm a nurse by trade, I'm not an accountant, I'm not a fiscal person, although I have to be. But I'm here because I really wanted to try to change the world, to help people. But we have to do that in such a way that we're mission focused, but we also have efficiencies and we're able to get the outcomes that we need. So just quickly, some other forces on us. We clearly, Medicaid managed care is the big one pressuring us and helping to direct our system. The triple aim, which Jason talked about, I see that as my sort of true north of where we're trying to head. So I think that can be a grounding point for all of you. Are the kinds of services that you're involved with, are the activities that you're engaged with, improving the health of individuals with behavioral health conditions? Are they improving individual outcomes? And what is that outcome and what's your per capita cost? Those are really critical elements. Parity. Parity was a great thing in New York State when it came in. Timothy's Law, we were thrilled to have that. I think what we found with a few years under our belt with that was it was an important first step, but it needs to continue to evolve. That just having a benefit that says you have a behavioral health benefit is insufficient. You have to have adequate network, you have to have adequate reimbursement, you have to be able to get an adequate dose of services. So I think that's another force that's out there, particularly when our system that was very heavily, sorry Jason, but very heavily Medicaid dependent for serving a broad range of people. As we really narrow that down, we have individuals that we need to be able to access care and treatment through their insurance products and do that at a reasonable pace. So again, parity is a big issue for us, and also Olmstead. So this is a housing conference. Olmstead is a very significant force for us, and my push, my pressure has been, I want to get out ahead of that. Some might call me a bit of a control freak. I'd rather control our own destiny as New Yorkers and say how we'd like the system to look rather than have that dictated by outside forces. To give you a sense, Donna mentioned the listening tour, and so for all of you who are struggling as providers, agency heads, to figure out how to structure your agency, how would you like to be in my shoes? And that I operate 24 state-operated psychiatric hospitals. The next comparable state to New York has 8 or 5 or 4. So we are the textbook definition of an outlier within that. And believe me, as I've been out doing 30 stops across New York State, people have said, well, it's sort of with their hand on their hip, you don't want to be like Texas or California, and I hope nobody is here from Texas or California. And I said, that's not my point. My point is to say we have we are one behavioral health system, so it's not sort of this side and that side. But in this one behavioral health system, we allocate so much of our resource to that high-end institutional care. So with those 24 hospitals in the Office of Mental Health, anybody want to take a guess? So we serve 1% of the population in the public mental health system. How much of the funding of our collective behavioral health bucket do you think we spend? Anybody?
A lot.
A lot. All right. So for 1%, it turns out to be the fun 80-20 rule. But so 20% of the public mental health resources are in our system. So, what I set out to talk to our workforce, to talk to community providers, county and city mental health people, other providers. I met more mayors, economic development people than I ever thought cared about mental health in this 30-stop tour. So what I was saying to them is this is not about we need to just close all of the state hospitals. They don't have a role. They don't have a purpose. It's about finding who we are and what our niche is. And what I see our niche is shifting away from that institutional footprint and really moving ourselves from that safety net identity, which is a very institutional identity. A safety net identity is not consistent with recovery and resiliency. And yet where I do see our role is really in working with individuals with the most complex forms of mental illness if they're an adult, or emotional disturbance if they're kids. And I want to see us be best in nation care for those really complex individuals. So they haven't been able to figure out what's going on with them. They may come into our service to have that intensive diagnostic work, that treatment plan developed. And then I'd like to see us shift ourselves and work more closely with the community around how do we do a much broader array of community supports and services for individuals to really thrive in the community. And so with that, given that you gotta sort of deal with the facts that are in front of you, we cost more. There are things that we are good at, there are things that we are not good at. So like for instance, housing, I don't see us expanding housing. And I'm not just saying that because I'm at a housing conference. I did say that. So what are the services that make sense for us? A low cost, high volume service is probably not something that's best for the state. So I've taken this vision out across the state, out to our folks, and have said, you really have to rethink who you are, what you do, think of a different business model. I got about 2 hours at each of the 30 stops, so that's like 60 hours worth of input back. And we're processing that, and I'm going to come out with a plan July 8th. So I hope you'll all be looking for that, and I hope you'll all help us with the continued evolution of that. Another thing to just sort of bringing us all back into that, to the behavioral health bucket, I think our past 20 years of New York State policy, and this is the most simplistic version of it ever, but is that care in the community is good. We want to reduce inpatient beds and staffing levels as we can, and we want to reinvest in the community as we can. And I think those might work now if the entire health system wasn't changing around us. And the difficulty that I see with that is that until this year, we really were budgetarily even two systems, the state system, the local system. And we sort of skirmished with each other around, well, does the state system have more, or we need more reinvestment, and we want 100% reinvestment. And so we'd sort of battle with each other. And meanwhile, this big, crane was coming in and scooping money out of the behavioral health system as we had a flat budget. And Jason, your comment about the $2 billion that went to the federal government, sort of the same thing, that as New York was sort of, working, this big, payloader came in and took resources out. So, we do have to rethink the way that we look at our system. I'm not going to say anything more about centers of excellence, just a few added elements around Medicaid managed care. The two sort of flavors or varieties that we're looking at, one would be that all of the Medicaid managed care plans would have to qualify to be able to manage those higher end behavioral health services. So I think that's outstanding. I think that's reflective of the importance of the partnership that the O agencies and DOH have in designing this. That, Jason, I think for us is a real opportunity to say, not, you're never going to be able to do this plans, but what is it that we're looking for? What represents having the capacity, the policies, the decision-making, the medical necessity, the metrics to be able to do that well? And we are working to define those qualifications. Plans would also have the opportunity to be a HARP. And the health and recovery plan is not just a cute rebrand of a special needs plan. It was really our team stepping back and saying, there were a lot of preconceived ideas about SNP, and as it related to behavioral health, it failed once, so we didn't want to necessarily go back down that road. And I like the title of health and recovery plan, even though HARP is a little cutesy, because it does include health. So in addition to recovery, it includes health. So I think that's a strong piece. The HARP is an integrated benefit. So that means it has, it's a separate line, product line. It has health services, behavioral health services. And the extra added bonus to this is that there are some additional, in plain English, more recovery-oriented services. So, creative respite, creative peer services. For those of you who like playing in like the CMS numbers, it's like the 1959-like services. So there would be some more flexible benefits that would be in the HARP that would be, I think, particularly enticing and effective for individuals who would be in that particular plan. In terms of time frame for New York City, adults who are Medicaid only would be going into the plans in April of 2014, upstate adults in the fall of 2014, and kids in 2015. Let's see, what else? In terms of housing, what I would say from the OMH standpoint is, every day I am incredibly thankful that I have Bob Myers and Moira and the team that we have at OMH. They are passionate about housing. I think they know it very well. I think they reflect the concerns, the ideas, the directions that you'd like to go to me on a daily basis. And again, they are very passionate and very directed around housing. We know we need more of it. It is the single, in those 60 hours of feedback that I got, that was number one. We need to have more safe, affordable housing. So that is out there. I see us bearing part of that. We did expand housing in this year's budget. I see part of that looking to Jason and looking at MRT reinvestments, which, again, they've achieved that in this first round, and that's important. But I also see us working with communities. And so one of the conversations that I've already started to have with various county executives and various communities is we have a lot of property within OMH that is, older hospital property. Could we potentially work with communities to look at alternative uses for that property and in exchange get affordable housing? So I'm willing to look at any resource that I have working with people to be able, and working with communities to expand safe and affordable housing. The last sort of challenge for you that I would leave you with is to really think, as we're talking about managed care, not necessarily about how do we keep the models that we have today, but talk to me about some of the needs that you see for people, and how do we get more housing, and then how do we have a menu and access to services that people need that, again, can be, I think it has to be more innovative than it is today. I think we clearly need different levels of access. But those services may or may not be attached to housing. And so how would we access them? What would they look like? This population, where some of the challenges are today, and that's really critical stuff for us. So thank you, and I look forward to your questions.